Yeah, it's a great pleasure to welcome you to the closing plenary session of this year BMC Congress, the first and hopefully the last virtual or purely virtual conference we had. And it's a great honor for me to introduce you to one of the most famous management scientists worldwide, Henry Mintzberg. Henry Mintzberg is Cleghorn professor at Berchtold University for many years. He was a visiting professor at INSEAD and at the London School of Business. Everybody who studied management knows him for many years out of the literature. His breaking through book was in 1973, published under the title The Nature of Managerial Work, where Henry analyzed what our managers are really doing, in a sense, what is the daily work of a manager. And it's quite amazing. And here we have a couple of his books, and you see his first book from 73 down at the left side. And it was pretty much, in a sense, changing the paradigm that manager, in a sense, acting rational, planning, executing, controlling. And indeed, what they are doing is very fragmented. And people ask him, in a sense, or after he published the book, a lot of people said, well, that's something we knew already for many years. But he said, well, but indeed, I'm the first one who wrote it down. And that changed very much the way how we looked at management. Henry is, in a sense, coming from a purely management perspective, and that's something which, from a European understanding of managed care, is fundamental. When we define the term managed care, one part of the definition of managed care is always, in a sense, to look what could we learn from other areas? How could we apply management principles, management practice into the healthcare system? We asked Henry to start to give an introduction and to focus on a couple of things which are, to our belief, fundamental. And after his 20-30 minutes introduction, we'll have a discussion with Peter Berchtold and Christof Schmitz, in a sense, to discuss more in detail these topics. First question is, in a sense, the Swiss cross model. This is, in a sense, how to combine care, cure, community, and control, how to close gaps between different ways of thinking, different, in a sense, management approaches. Secondly is a question, in a sense, what could we learn from other industries? And what I mentioned, what I didn't mention before, what I should have, one slide back. And we published this book, The Managing the Myths of Healthcare, which is a tremendous, exciting book, which he published in 2017, where he analyzed, in a sense, a couple of myths, and we would like to focus on some of them, and I highlighted five out of them. When you look into the literature, when you look at the literature from Henry Mintzberg, there are a couple of things which are fundamental. First of all, and very important, and we'll discuss it later a little bit more in detail, we should not consider healthcare as a business. Secondly, we don't need heroic leadership. We should much more, in a sense, look how leadership and management is related in healthcare. Thirdly, in a sense, the question of management and leadership, how it works together. Fourthly, the relation or the reality of strategic, and I like very much the term he used very often, since he's talking about the nonsense of strategic planning. He's always saying, in a sense, real strategy does not come out of real planning. It's much more, in a sense, something which is happening, which is evolving. And lastly, in a sense, two things which I would like to highlight before the floor is to Henry, in a sense, the critical function of training. That's something we'll also discuss later a little bit more in detail, and understanding, in a sense, what means evidence in healthcare. And we'll have first, in a sense, the introduction from Henry, and then we'll have the discussion on the three topics, in a sense, healthcare system and management. Very important, the role of competition. And Henry quoted once, which I like very much. He said always, when you live in a country with very little competition, you're always looking to countries with a lot of competition and vice versa. So we're always looking, in a sense, what we don't have. And lastly, in a sense, the future recommendations for change and policy making in healthcare. Please, whenever you have questions, post them in the chat. Patricia is in the setting, sitting next to me and collecting them. And then we would like to also integrate your questions in the discussion we are having later. But now, in a sense, the floor is yours. Henry, we're very excited. We're very proud having you here. So please go ahead.
Wonderful words. Thank you. That's a great summary. Sounds excellent. Good. I'll start with, sort of where you left off in a way, because the thing that intrigues me most about healthcare is that everybody is convinced their own healthcare system is failing, and everybody complains incessantly about healthcare in their own country. A friend of my daughter's is a fancy radiologist. We were at a party, and she cornered me and was going on and on and on about how terrible healthcare is in Quebec. In Canada, the provinces run the system, and complaining bitterly about Quebec. And finally, I interrupted her. I got one moment. I said, "Well, what about the American system? You did your residency there." And she threw up her hands and she said, "Don't get me started on the American system." So nobody has a good system. A friend of mine in Italy, some of you probably know her, Paola Adenolfi, was telling me about the same thing about Italy and how people are so complaining. And I said, this was some years ago, and I said, "Well, how about healthcare in Italy? How does it rank?" And she said, "Oh, we came out second after France on the WHO ranking, the 2000 ranking of healthcare. So second is not good enough, and first is not good enough, and everybody complains incessantly." And my conclusion is healthcare is not failing at all. Healthcare is not failing. Healthcare is succeeding. We live longer. You people have all kinds of brilliant ways of saving our lives and extending our lives. I wouldn't be here if not for a quadruple bypass operation. But you do it expensively. That's awful. You find these wonderful ways to save our lives, but you do it very expensively. I don't mean you're overpaid. I mean these are expensive procedures, and we don't want to pay for it. Well, why should I pay because you're sick? If I'm sick, of course, spend everything. I spent $2.50 for my open heart operation because we rented a television set in our room and the government paid everything else. But I don't want to pay taxes for your health care. I only want to pay taxes when I need it. And so we keep cutting taxes. The system gets squeezed, and then we claim it's failing. It's failing because it's succeeding. And we need to kind of see it differently. And we need to recognize that we have to face this problem. And then what we do is we don't recognize this problem as such. We intervene in all kinds of ways, a number of which were just mentioned. We intervene in all kinds of ways that are dysfunctional. So we measure like mad, for example. We measure everything we can. If I need a really, really difficult operation, I'm going to find a surgeon who's got a high death rate. Not because that surgeon is incompetent, but because that surgeon gets the tough cases. If I have a surgeon who has a very low death rate, I kind of wonder if they're getting the tough cases. Measurement is necessary, but very tricky, and we have to do it very, very carefully. But people outside the system, sort of in management, in control, in government and insurance companies, outside the practice, tend to overemphasize things like measurement. Planning. Planning is important, but we don't plan strategy. Strategic planning is an oxymoron. It's we learn strategy, we don't plan strategy. And in healthcare, we have a very particular approach to strategy, which is venturing. The strategy of every general hospital kind of looks very much like every other general hospital. Where's the strategy except for the geographic niche that they do in one part of Berlin or in Milwaukee or wherever it is? But they all look very similar. What makes them different is the venturing that happens. Some lung specialist in some hospital creates a famous lung laboratory or a lung service, and so on and so forth. So strategy is venturing. It's not planning. Competition and being like business. One of the questions is, what can healthcare learn from other industries? And my inclination is to say less. not more. I don't want to say you can't learn from others. Of course, learn from others as long as you maintain your judgment, as long as you realize that healthcare is different. For one thing, it's not a business; it's a calling. People are in healthcare, the best of them, largely because of the service they want to give, not to make lots of money. They don't mind. Physicians don't mind making lots of money. None of us mind making lots of money. But competition, in a way, of course, competition is another of the big answers. Leadership is one. Get the great leader, everything will be fine. It's interesting that Germany has one of the great political leaders of the world, Angela Merkel, and she's about the most modern head of state I can imagine. And America had an immodest head of state up until a few hours from now. About that. So we have leadership as the solution, and so on and so forth. And competition. Michael Porter is very big on competition. Well, I think healthcare has too much competition, and I don't mean the competition he's talking about. I mean the competition between physicians for beds, between different medical specialties. Everybody's fighting for beds. Everybody's fighting for budgets. Everybody's fighting for to get more and more and more for themselves. Believe in what they're doing, but that competition is dysfunctional very often because we need more collaboration and not more competition. And I'll come back to that in a moment. I did a study in the Jewish General Hospital in Montreal, just looking at all kinds of things. I published an article, and the big issue in the hospital at that time was the emergency room. It was overwhelmed. I asked them at one point, I asked the head of ER at one point, what's the difference between a stretcher and a bed? Because they kind of looked the same to me. And I realized that the difference between a stretcher and a bed is that the number of stretchers can be extended. That's why they call them stretchers, because we can get more and more, whereas the number of beds is restricted. So cardiology can only have, 22 beds or whatever, whereas the ER keeps stretching the number of stretchers. Anyway, this problem was festering. They were just overwhelmed, and this problem festered for years. And I attended all the meetings that were related to this. So the medical executive committee met, and because the ER head was on that committee, they talked about that incessantly. And the nursing committee met, and they talked about it incessantly. And the management committee met, and the board met. Okay, cure, care, control, community. Cure, physicians, or at least treatment. Care, nurses. Control, management. Community, the board. They all met separately, and nothing happened. And then the government turned around and said, you know what, we're taking $2 million off your budget if you don't resolve this problem. So they took the assistant head of nursing. She created a committee for the first time of people from all four quadrants, care, cure, control, and community, and they solved the problem in a few months. We need more collaboration in healthcare, not more competition. Certainly not business type competition. Frankly, I don't choose my physicians according to price. I don't pick my surgeon according to who's going to give me the best price for an open heart operation. That's just not the way it works. I have to trust the physicians and trust the people making those choices and function in that way. So, and let me go on to some other aspect of collaboration. To my mind, the great strength of healthcare is its debilitating weakness. I'm saying that the strength of healthcare, the greatest strength of healthcare, is also its most debilitating weakness. The great strength of healthcare, particularly medicine, is to fit us into your categories. So I have a pain in my lower right side. Good, it must be an appendix attack. Check it out. Sure it is. Terrific. I'm in a category. People know exactly what to do. They cut me open or put a laparoscopic thing in or whatever they're doing these days, take out my appendix, and everything's better. And this is amazing. I mean, I had 4 blockages or whatever, and this spectacular piece of surgery goes in. They measure where it's blocked, how it's blocked. They go in and put in the bypass material, and lo and behold, 6 years now, and I haven't felt anything in my heart other than emotional, but nothing. I haven't felt anything physical in my heart in 6 years. Maybe they took it out altogether. I don't know. But so that's fantastic, and medicine likes to what I call the 3 C's. They like to categorize, commodify, and calculate. Basically, get us into their categories, and it works brilliantly for a great deal, and that's the great success. The great weakness is when we don't fit the categories. And to my mind, we don't fit the categories in 3 possible ways. One is there's no category. Medicine doesn't have a category for IBS. IBS, irritable bowel syndrome, is a label, but it doesn't say much. There's no category for it. And if we're in that category, we get dismissed. I don't have IBS, but I know people who do, and they just get dismissed. There are many things where we don't fit the category. A lot of mental health. We have the categories, but they're not very good. A lot of them. Not all of them, but a lot of them. In manic depression, we're better at treatment. In much else, we're not. Yesterday, I heard a talk from a number of people in the McGill medical faculty. We meet once in a while, and I join them, about suicide, and our knowledge of suicide and sort of how to predict it and deal with it is really, really very weak, according to the first person who presented. So that's when we're outside the categories. Then there's the problem of cutting across the categories. When we're geriatric, we present ourselves with all kinds of different things, and unless the physicians can establish an order, I've been told that cataract need to come last. You have to resolve everything before you do the cataract operations. Unless we can do an order so we have nice, neat categories, it's very hard to get people to collaborate. One team of geriatricians, or not geriatricians, but geriatrics in a Montreal hospital, he used to say that his best diagnostician is a physiotherapist. In other words, somebody who was not a physician was as good at diagnosis as physicians, because they worked as a team, and that was unusual. The third one is the one that most interests me, which is getting beneath the categories. You probably know an article. If you don't, I recommend you read it, by Atul Gawande, called The Bell Curve, in the New Yorker. It's a brilliant, brilliant article. Every physician should be reading that article. And essentially, what he went to visit the world's leading authority on cystic fibrosis, and this guy created the protocols, and people were following his protocols, and yet he did better than anybody. And Gawande wanted to find out why. So he visited him, and the physician was seeing a young female patient, and he was questioning her about whether she's doing all his tests, and not tests, but his procedures that he insisted she do regularly. And she said yes. And he turned to Gawande and he said, well, that's good, because her some lung reading is a bit low, and she'll take 3 years off her life if she doesn't continue to do these procedures. At which point she broke down and said she had a new job and she had a new boyfriend, and she couldn't deal with it, and she wasn't doing them the way she was supposed to. And he said, okay, let's work it out together. That's beneath the categories. The patient became a person, and that's why he did so well, because he went beneath the category and treated the person and not just the patient. So just some ideas. I'm working on a kind of an article with a colleague of mine, a physician, called "The Case for Cause." I get into big fights with physicians when I say they don't give enough attention to cause, but they're much more about cure than they are about cause. And so is everybody else. When we march for breast cancer to raise money, are we marching for cure or for cause? We're always marching for cure. We want a cure, and we put our money into finding cure. And of course, we need cure. But if we understand cause, we may not need cure, because if we understand cause, we can stop it. You know, if we know that lung cancer is caused by smoking, we can do things to stop smoking and not just figure out how to cure lung cancer. And so, or treat lung cancer. And so we need to give more attention, I think, to the case for cause, much more attention to the case for cause. But physicians are not trained so much to do that. They're trained to treat, just as they're not very well trained, at least where I come from, in diet. But diet is a big factor. Right now in the pandemic, and we can get to this later, I've been giving a lot of attention to the role of pollution in the spread of the coronavirus. And pollution could be a major factor. You can look up on my website, mintzberg.org, on the upper right, there's some material on that, a video and so on. But I haven't been able to get anybody's attention because the epidemiologists are absolutely in their category, which means they don't want to listen to some dumb management professor sounding off about pollution. But many diseases are pollution related. Asbestosis is pollution related. Lung cancer is pollution related, and so on and so forth. So, okay, and then just to finish off quickly, in healthcare, it's a profession, it's a calling. Management has to be distributed. It's a phrase meaning that it's not only managers who manage. Other people manage. Physicians manage their own practice. Physicians manage their own patient load. But they also have to play a role in managing the hospital or the other organizations they work for. When I meet a physician, and this has happened many times, who said so-and-so has become the director of medical services, he's no longer one of us. He's left. He's a traitor to medicine. You know what I want to say? I want to say, good, we'll put in an accountant instead. We'll find an MBA to do it. We'll make the head of medical services an MBA or an accountant. You know, I mean, it's just a ridiculous attitude and anti-collaboration. You know, congratulations to the physicians who take time away from their practices to do the necessary managerial activities. Strategy is the sum total of ventures, as I mentioned before, in a hospital. Strategy is mostly what physicians and other people do to introduce new kinds of services, new kinds of treatment, new kinds of research, and so on. That's strategy. It's not sitting up there and going through some strategic planning process that goes nowhere. You know how we're dealing, to take something else that's similar, you know how we're dealing with global warming, with climate change? Our governments are making 30, 40, 50-year plans. 4-year governments are making 40-year plans. Think about it. Obama makes a plan and Trump comes in and ends it. Trump ends the plan. Biden comes in and starts it again. He rejoins the Accords, the Paris Accords, and so on and so forth. We don't need plans. We need action on climate change and everything else. We need action. We don't need plans. We need action. Of course, we need to think ahead, but for 4-year governments, you're lucky in Germany. You've had a head of government who's been there for a long time, and she can carry things out. Good for you. We need to reframe ownership. We need to reframe competition and collaboration as communityship. I like the word communityship. Enough leadership. We go on and on and on. Leadership is about individuals. We need communityship. We need communities. And last comment is about reframing ownership. We think that organizations are either owned by investors or owned by the government. Well, I got news for you. Most of the interesting healthcare I know is not owned by the government, and it's not owned by investors. The most famous American hospitals, almost without exception, the Cleveland Clinic, the Mass General, in Minnesota, and so on and so forth, are all neither government nor business owned. They're not for profits. They're non-owned. Maybe they were created by a religious order. Maybe they were created by a union. Maybe they were created by just a group of physicians who got together. But they're not owned. I call it the plural sector. Beside the public sector and the private sector, we need to understand the immensity and importance of the plural sector, which is all those organizations that are owned neither by investors nor by their own, nor by the government. Many of them are owned cooperatively by their workers or by their clients, and some are owned by nobody. Most are owned by nobody. Nobody owns most of the great hospitals and universities in America. Nobody owns them. Nobody owns Harvard. Nobody owns McGill or Stanford, or nobody owns them. So we need to open up. And that brings us to something else, which I won't get into now, but it brings it to my book called Rebalancing Society. A healthy society balances public, private, and plural sectors. Most of the Western societies, particularly the United States and Britain, are utterly out of balance on the side of private sector interests, just like the communist countries were utterly out of balance on the side of public sector interests. And so let me stop there. I guess I'm about at the right time. So thank you.
That's absolutely perfect. Thank you so much, Henry. This was really, really inspiring. I get so many things which we should discuss. It will be very difficult for Peter and Christof later on to make a choice. Just let me summarize a couple of things before we enter into the talk. I think one of the things which you mentioned right initially is so important. In a sense, the problem of healthcare is not the failure, it's the success. And this shifts right away the mindset, how we look at healthcare, whether it's something which is wrong or something which is good, but we have to keep it under control. Secondly, and I mentioned it already earlier, and I think it was, again, very fundamental in a sense, the overemphasis of measurement, which does not mean, and nobody would say evidence-based medicine does not make any sense, not at all, but we have to look where measurement makes sense, where it does not make sense. The collaboration, and that's something which is very fundamental, because in a sense, this is the reason why our association exists. This is, in a sense, the goal either of the Swiss organization from Peter or our organization is, in a sense, the strong belief, in a sense, the cure in healthcare is to get the people together, working together, sit on the table, think together what could be solutions. And you mentioned it, in a sense, in the Swiss cross you develop with cure, care, community, and control. You have to bring these different people together. They are speaking different languages. They have different sets of goals. They have different, in a sense, also. Some are risk adverse, others are not, in a sense, and it's challenging, but it's the only way how to do it. I like very much your example, in a sense. You would never choose your doctor because of price. And this is so true, specifically when it becomes something serious. This is not the way how we make a selection. And maybe just two things to finalize. The way of thinking these categories, that's something where we should go into the discussion more into detail, because this is very fundamental. It sounds very easy, but when you think a little bit more in detail, it becomes really fundamental. It's something which is very hard and very difficult. Well, it's more than two things. Cause and cure. This is, in a sense, the mind shift towards prevention. In a sense, we have to look, in a sense, and you made it very clear, a doctor is in a sense, teach to treat. And we have to think where we should place prevention into a healthcare system. And in a sense, two last things. You said about the professionals, and it's not only managers who are managing. That's something which makes healthcare certainly very different. And I was really impressed, and I would love, Peter and Christof, when you go into your thoughts on the talk, that we think more about the ownership in healthcare. Because we think very often just purely in private versus public. But you mentioned when you look at these very admirable organizations like Harvard or whatever, nobody owns them. And that's something where, and it's something where we have to look whether we find solutions which might be in between private and public. These are so many things we could discuss. And I look over to Patricia. I guess she got a lot of questions from the audience. But I would like now to introduce two guests. Peter Berchtold, he's a physician by training. He's the former president of the Swiss managed care organization, Forum Managed Care. And Christof Schmitz is a sociologist and business administration by training. And both of them are very often applying, in a sense, the Swiss cross model into practical management projects. And I would love to hand over first to Peter Berchtold, his thoughts on your talk, and then Christof, and then we'll start a discussion with more a talk between the four of us and our audience about these very remarkable and so diverse different areas you mentioned in your talk. So I'm very excited about the next half an hour discussing about that. Peter.
Thanks again, Volker, for this introduction, and thanks so much, Henry, for this wonderful outline what the challenges of today's healthcare systems and healthcare provision is. And as we already discussed, we really truly like your picture of the cross-cure care, control and community, because we really think, and we work a lot with that, we really think that describes reality in healthcare very well. And one point which is important at this stage, that what you said about categorization, and by the way, I'm mentioning that because I was trained as a medical doctor, and I really truly know what categorization means and what the value of categorization is within medicine, and that is the reason why the myth healthcare is failing is wrong. But at the same time, as we know, it might be also true because there are a whole bunch of failures and facts. And by the way, that might be because for a long time, there were only a few categories within medicine. If I just look back to when I was trained as a medical doctor, internal medicine there were only few categories. If you look at healthcare today, and especially tomorrow, I mean, we have probably to expect a kind of an explosion of categories. So my first question is, because I think this is truly a very important point, what does that mean, and what do you think, and what could help us to kind of get into a more functional system if we at the same time see this, let me call that, explosion of categories? Henry?
Okay, a couple of things. We have a program called the International Masters for Health Leadership, IMHL.org. It's a wonderful program, hugely successful, that has people from all over the world, mid-career, typically in their 40s, but anywhere from 30s to 70s sometimes, and almost all with practice on the ground. Most physicians, lots of nurses, public health, all kinds of things. And one time, or a number of times actually, I polled the class as to whether they see themselves as more evidence-based or more experience-based. And now this is not a random sample. It's a sample people choose to come to a rather innovative open-ended program. But they range all the way across, and not that many way over to the evidence-based side. many in the middle. Some of the most sophisticated surgeons have put themselves on the experience-based side, and so on and so forth. So it's a kind of an interesting relationship. Before I did this, I don't know, forget my writing on the top, but I did the, can you make that out? The Swiss cross. I decided not to use PowerPoints. I'm not a fan of PowerPoint, but the arrow up is managing up, and the arrow down is managing down, and the arrow to the right is managing inside the system, and the arrow to the left is managing outside the system. So physicians manage down. They're in the operations, but they don't even report within the hierarchy of the hospital, for example. Whereas the nurses are down on the ground here, but very much reporting within the system. Then there's control, which is removed from the ground, but inside, and community, which is removed from the ground outside. The key issue of collaboration, how you get to each other, not only across medical specialties, but between nursing and management, between nursing and but between nursing and medicine, and so on and so forth. There are all kinds of, on the book, curtains. There's professional curtains, medical curtains, there's administrative curtains, all these things. When you bring down the curtain, you separate from nursing, you separate management from medicine, and so on and so forth. And we need to do something about that. Now, in terms of the question, which I wrote down, how do you deal with the explosion of categories? I never kind of thought about it that way, but it's a lovely term. And of course, the more explosive the categories, the more specialized the people in the categories. They know not only about other specialties, but even about other specialists within their own specialty. And so we keep going narrower and narrower. I don't have a magic formula for that, but it seems to me that you can go to either extreme. You know, general practitioners can't treat everything, but the other extreme is to be so hyper specialized that if you fall within this very precise category, they can deal with it. Maybe the answer lies in that chief of geriatrics, you know, commenting on I think he said a physiotherapist, I can't remember, but saying that she was his best diagnostician because they worked as a team, because they worked together, because they took the time to interact. And I think, you know, historically, physicians, if they needed a consult, they scribbled a few words on a piece of paper, but that nobody but another specialist could read. The other specialist read it, scribbled a few words, and sent it back, and that was considered consultation. There was something I read years ago by a famous surgeon who has his cookbooks, and he says before every operation, I have on one page every operation. I have the steps, up to 40 steps for every operation. I take a minute or two before the operation to review them, talk about categorization. Then there were comments about M&M, morbidity and mortality meetings where they do patients every 10 minutes. Well, that's time enough to categorize, but is it time enough to do some really sophisticated problem solving? Because if you can solve a problem that somebody's got that nobody knows how to deal with, you've got not only a publication, but a new category to deal with that thing. And it's the creation of categories that's as important as the application of categories. So I can't answer the question because but frankly, I think people on the ground who are struggling with it have to think about answering those questions in their daily work. I'm sitting in my house in the country. I've been in our apartment in Montreal for 2 days in the last 9 months. We're very well protected in the country by a lake. So I'm not doing a lot of healthcare. And by the way, it's just as an amusing aside, all my little geriatric maybe problems that I came here with, almost all except the cataracts, they don't go away. But all the others have kind of magically dissipated. And Maybe it's just the good air and the good food. Maybe that's the secret.
So we looked at the first, in a sense, remarks from Peter Berchtold, and I would like to switch to Christof Schmitz. What are your thoughts?
So thank you, Henry, very much for your interesting thoughts. I would like to stick to the Swiss cross, not only because I'm a Swiss, but because I think this concept is really fantastic, and it's a fantastic explanation of so many experiences people are making in these systems. I have told this concept together with Peter several hundred people already working in hospitals and healthcare, and everybody was saying, yeah, that's it, that's my world. Nobody was saying we are beyond that, that's gone, it's still true. And even if you are reading Florence Nightingale, the grandmother of care, in her Notes on Hospitals, 1866, she was writing about every hospital has struggles between physicians, nuns, and administrators. So we have the same problem since, let's say, at least 150 years. And you said the interesting thing in healthcare is its greatest strength is at the same time its biggest weakness. So what's the strength of this system, of these four worlds, and what has management to do or to avoid to go beyond that?
I did a blog. You can look at my blog, mintzberg.org/blog, but I did a blog comparing pat and playful ways of dealing with problems. The pat way to deal with a problem is the standard established way to do it. And mostly we apply standard things and do it. I want to ask, where's the playfulness gone? Where has the playfulness gone? You know, in the pandemic, I've been battling with epidemiologists just to entertain the thought of pollution, and they refuse. You know, Dr. Snow, I'm sure many of you know the story of Dr. Snow with cholera in 1854 in London, where everybody thought that cholera was transmitted by air, and he thought it was transmitted by water, and he proved that it was transmitted by water. He proved that they took the handle off the well where people were getting sick, and yet it took 12 years for people to accept that it could actually be transmitted by water. More people died of cholera after they knew this experience. And so by playful, I mean open-ended, just willing to entertain other hypotheses. We don't have enough playful people in the world. We don't have enough people who are willing to say, why not? Instead of why. You know, why is, come on, it's a crazy idea. A friend of mine who's infectious disease, wonderful guy, good friend, the most helpful physician I know. Every time I have a question, he is so happy. And he went through the whole litany of why pollution can't possibly have any important bearing on the pandemic. A graduate of our healthcare program, an epidemiologist who's in the thick of it at the WHO, dealing with it, at one point said, okay, Henry, maybe 10%. Maybe pollution can explain 10%. And I'm sort of listening to this and saying, why 10%? Why not 12? Why not 70? Why not 90? Why not 2? Why 10? Where'd 10 come from? You're this terrific scientist, and you're telling me 10% out of the air. But when they were dealing with cholera in London, they were so busy treating their patients that they didn't have time to entertain Snow's alternate hypothesis. So while they were running around, Snow took the handle off the well, and it all stopped, and they stopped running around. So there are times when it doesn't mean you're going to spend all your time, but there is so much of this. I mean, 40% of the American electorate, let alone how many among the 60%, are just like this. They can't see anything else. A friend of ours told us that Donald Trump has won 2 Pulitzer Prizes. I mean, Donald Trump has won. She believes it. I just like, there's such resistance to lateral thinking. It's scary. The technology may be a factor. You know, that we're so swamped with emails and everything. I don't know. Not a good answer, but.
No, absolutely. And I think a very, very important remark in a sense that what is missing is, in a sense, people who think differently and one of the things indeed with the Corona crisis, at least in Germany, we saw a lot of people discussing, writing papers, and there was a very strong discussion within the communities, and not only in healthcare, but with people from education, from the law side, in a sense, bringing different disciplines together and thinking about what could be or how we should think about the pandemic. Peter, we said we have a couple of questions and would like to go through a couple of core topics, in a sense, starting first with the management aspects. Peter and Christof, what are your main questions you would like to raise to Henry?
Well, I would like to start with or mention one, I think, a very important topic, which has already been mentioned by you, Volker, Amelung. Henry, you said this leadership versus communityship, and what that means for ownership. I mean, just living in an area where most hospitals, not all, but most hospitals are public. We have quite a lot of private, but most are basically publicly owned. Now, knowing that United States is completely different in that sense, what would you say to this area where we are living, where most hospitals are public? Is that okay, or should there be something changed?
You know, it depends on how public. It depends on how forceful the public sector is in controlling and how they choose. They need to exercise control because, as I say, you've got budgets that are only so much, and you've got to exercise financial control. So there has to be some kind of control. But the question is how they exercise. And you know, I said before, I don't know how it would rank now, but my own experience sort of accords with this, that France seems to have a very particularly effective healthcare system. My understanding is that while clinics can be private, I think hospitals in France are mostly public. I've had 2 or 3 encounters where once I banged my head and I was bleeding in a park in France, and my head was bleeding profusely, not because I did anything bad, but because it was my head. And so they took me in, and I've had three different experiences where the service was amazing, and that's public. So public doesn't have to be bad. I would suspect that Germany is smart enough to do that. I would suspect that America is very reluctant to put emphasis on the public sector because it manages the public sector so badly. If you don't believe in government, you're going to get rotten government. And the Americans don't believe in government, so they get rotten government, and that's a big part of how the pandemic is being managed, or at least not the pandemic, but particularly the vaccines. In Canada, we're sort of in between as usual, but we had a minister of health previously who essentially nationalized all these non-owned hospitals. He fired all the boards, fired all the chief executives, grouped them together. So you had 6 or 8 or 10 healthcare organizations under one single manager. Now, how did he get away with that if they were the plural sector? Because they get their money from the government, so they couldn't fight him, or they didn't have the guts, the courage to confront him legally and say, we are not a state-owned organization. You have no right to eliminate our boards. But they accepted it. So that kind of stupidity doesn't help in the public sector, and they've got it wrong time and time again. A friend of mine who's very knowledgeable, Sholem Globman, I co-authored the Quadrants paper with. He says, doesn't matter what you change in healthcare, just don't change so damn often. It doesn't matter how you organize, just stop reorganizing all the time. And the British National Health, or the National Health Service of England has been described as being in constant reorganization. It's just always reorganizing. They don't know what to do, so they reorganize. Or as one of their people said, when asked why they measure so much, he said, "What else are you supposed to do when you don't know when you don't know what's going on?" Well, we had in our class that we held once in England, we had the guy who's in charge of all the auxiliary services for handicap, for older people, for juveniles, whatever, all kinds of auxiliary services. Huge, absolutely huge, not part of the NHS, but next to it and huge. And he said, every Friday I spend in the field. First, I interview the recipients of the service without the professionals. Then I interview the professionals without the manager, and then I interview or speak to the managers themselves. So that's what you do when you don't know what's going on. You get out and find out what's going on. I don't care if there's 50,000 people out there. Speaking to 10 of them is better than speaking to none of them. So you get out there. You find out what's going on. You see what's going on. You get on the ground. You get out of your darn office. We could change a lot of management if secretaries put thumb tax on the chairs of their bosses with the points sticking up and said, these are going to sit on these chairs for 50% of the time. You are not allowed to sit down. Go find out what's happening.
Or we ask you to place questions in the chat, and Patricia is sitting next to me and selecting them and bringing them together. And now we will switch quickly, and she will show what's coming from the audience.
Yeah, thank you so much. There have been lots of comments already in our chat, which we followed. Among others, who asked who could recommend you for the Nobel Prize, by the way. But that's not what I'm asking now. My question is that we heard.
I'm busy in December, sorry.
The question we had was about the competition we just discussed. It was said, the competition about what? Is it about profit or human value? Can you maybe elaborate a bit more on that?
Okay, just to make one comment about what you said earlier. The managing the myths of healthcare. Here it is. If you in English, I don't know if it's been translated, but it has failed by market standards, by competitive standards. It hasn't sold much, believe it or not, and I don't know why. I mean, I put these things out, and I don't know. One of my friends says I'm 6 years ahead of everybody, so just be patient. I don't know, but that book has not particularly taken off. Maybe in Germany, but you know, with me and the Americans, I'm Canadian, so I think anything comes from Canada, the Americans kind of say can't be interesting. Who knows? What kind of competition? Of course, Michael Porter is referring to market competition. He's referring to the fact that one hospital that does heart surgeries has a better performance and proves itself to be better, and therefore you beat a path to their door. Michael Porter likes specialized hospitals because he likes strategy. He doesn't like organizations that don't have strategy. And as I said earlier, if a general hospital doesn't have strategy other than being in a geographic niche, namely a city or whatever, then he doesn't like it. So he wants them to have strategy, market strategy, namely lung conditions or mental health or whatever. It's a kind of nice idea. The trouble is that the emergency room has to be able to send people locally. You know, they can't ship everybody off to all kinds of different places. So we have lots of specialized hospitals, but we also unfortunately need general hospitals, and we build the specialization within them. There's a wonderful story of the United States some years ago where only 2 hospitals in the entire country had helipads to bring in patients by helicopter. At that point, only 2 in all of the United States had them, and they were a few miles apart. In other words, the only place that had them had 2. Nobody else had any. That's ridiculous. You know, it's a kind of mine is bigger than yours kind of competition. So Porter talks about market competition. I'm talking about competition internally or even across institutions, not competition in the market sense, but competition for beds, competition for budgets, competition for the great physicians, and so on and so forth. And we could use much more collaboration across all of that. Yes, we need competition. And yes, if I'm having a physician, I'd like to know what the patients have said online about the physician. But we can't use that business model. It's failing in business. The business model, this heroic leadership, central management, strategic planning, obsessive measurement, it's failing in business. And yet that's the model for healthcare. Please save us from that. We don't need that. The great American businesses are not the old established businesses that are doing all this. They're the new brilliant startups, whether it was Steve Jobs and Apple, or whether it's Google, or whether it's Amazon. They're not managing that way. They're not managing that way. I don't know if, maybe they have strategic plans at Amazon. I don't know. But that's not what makes Amazon so brilliant. Partly it's because they were in the right place at the right time, and partly because they had this audacious strategy to be the retailer to the whole world. Imagine being the retailer to the whole world, delivering it to your door, and then along comes the pandemic, and sitting at our door 3 packages right now. We're waiting for all the viruses to leave them so we can open our 3 packages that came yesterday.
Do you have an idea why politicians are so reluctant toward collaboration? Why is it so hard to sell the idea of collaboration to politicians?
It's an interesting question. Well, they compete with each other, but lots of people, businesses compete with each other, and then when they want tax breaks, they know how to collaborate. The strength of the private sector is its ability to collaborate when they want something. The weakness of the plural sector is their inability to collaborate when they want something. If you go to the World Economic Forum, boy, they got their arguments down pat, and they're developing their arguments for the private sector. Go to the World Social Forum, it's pagaille, as they say in French. It's chaos. It's everybody for himself. It's they're supposed to be the great community organizations, but they can't get their own act together. But then look at Biden. Everything that Biden has done so far, which is not yet, I guess he'll be president in an hour or so, but everything that Biden has done so far has been remarkably collaborative. Even with regard to Trump, he's really held back. So not all politicians, and Merkel doesn't strike me as a highly competitive, non-collaborative. The women, maybe it's the secret is in women leaders, because the great women in the Scandinavian countries and New Zealand and so on have been some of the most effective with regard to the pandemic, and they're essentially collaborative. So maybe the answer to the question is men are competitive. Get the men out of politics. Maybe everything will be healthier. I don't know. It wouldn't be bad. I think the politician in Canada today is the deputy prime minister, who's a woman, and very, very collaborative.
I like this idea a lot. Christof, you already also prepared a couple of questions you would like to share with Henry.
Yes, I found very nice your mentioning of playfulness concerning management and the missing of playfulness. And of course, playfulness isn't fitting very much to key performance indicators or something like that. That's one reason, which is a problem. But at the same time, what I am really missing in healthcare organizations is a kind of fantasy. Everybody knows exactly how he has to deal with this kind of problems. The physician knows it, care knows it, everybody knows it. And kind of this playfulness would be very helpful, it seems to me. In your book, you were writing that management would be less distant and more caring. Could you elaborate about this point of caring management? What can that mean? Nobody has any idea about that in Germany.
Well, I think what I said just a minute ago about Merkel, about New Zealand, about the woman who's Prime Minister of New Zealand and the Scandinavian countries and so on, you get a sense that they care. You listen to Biden. I never met Biden. I wouldn't know Biden at all. But you listen to him and you get a sense he really does care. You know, George Burns, a comedian, once said about authenticity. He said, authenticity is everything. If you can fake that, you can fake anything. Well, it's funny, but it's not true. You can't fake authenticity. And you just tell, you just kind of know when there's some kind of authenticity, when there's some kind of caring. We look at someone on television and we say, you know, that's the kind of person I'd like to get to know. They really seem to care. You watch all our politicians or healthcare administrators on television talking about the pandemic, you can kind of pick out the ones who really seem engaged and caring about it. And you could tell that Trump, whenever he spoke about this, was reading lines and couldn't care less. So they're but you know, lots of people care. I mean, we see it in families. We see wonderful families where the parents care, they care about each other, they care about the children, they care about decency, they care about morality, and it's wonderful. You know, where my partner and I are working on a song here. There's a famous Weaver song called "Where Has All the Judgment Gone?" You know, where has all the judgment gone? And the song is "Where Have All the Flowers Gone?" But we're talking about where has all the judgment gone? And I think it's also where has all the caring gone? You know, there's no reason not to be caring. Your life is better, and so on. So again, an inadequate answer to an important question.
Absolutely. Very, very adequate answer. And Peter Berchtold is raising his hand. He has a question, most probably even already the final question. Peter.
Well, I like this song, Henry. By the way, just but let me just go back to the point of competition, because you mentioned one thing. You said that the problem with competition is that it is hindering collaboration. And would you say that there is a kind of an antagonism between competition and collaboration? Because that would be really, let's say, important, and wouldn't be what people, at least in Switzerland, think about. Here we often hear the idea that competition is actually fostering collaboration.
I think all those relationships are possible. I think an obsession with competition gets in the way of collaboration. A reasonable amount of competition could encourage collaboration. So I think it's a question of how, you know, we tend to overdo things these days, and you know, the word competition just appears so much. Particularly, the economists have had much too much influence on society, on healthcare, on many things. Yes, we need economists, and yes, we need to understand that dimension. You know, some of you may think that there's a Nobel Prize in economics. There is no Nobel Prize in economics. There never has been. There never will be. Nobel created 5 prizes, not 6. Economists in the Bank of Sweden created a prize for themselves and managed to call it in memory of Alfred Nobel, and everybody runs around calling it the Nobel Prize or the Nobel Memorial Prize. Economists got away with that for themselves in a very the economic dogma. Mainstream economics has 4 dimensions. Okay, greed is good, markets are sufficient, property is sacrosanct, and governments are suspect. That's the economic model. It's destroying us. It's destroying healthcare, and it's highly competitive. I want to add just one other thing before. When you're 10 years old, you decide to be a physician. And so your family says, oh boy, you better get good grades. You're going to have to study like mad. So from 10 until you go to university, you study like mad. You keep your nose to the grindstone. And you do what's told and you do it well. And then you get into university and you continue to do it in your general studies and your medical studies. And then you become an intern. And then you become a resident. And then you become a staff physician and so on and so forth. By this time, the playfulness has been driven out of you, driven out of you. It's like the French educational system. I think the way the French educational system works is they take smart students and they send them to the Grande École and they squeeze them like a rag that's getting the water out of a rag. They squeeze them and they squeeze them and they squeeze them. And when there's no creativity left, they release them on the market. Maybe too much of medical training does that, and medical preparing does that. We have a university you're probably aware of in Canada called McMaster that years ago started to do things differently in their medical school, and they started to accept all kinds of people in their 30s and 40s with all kinds of different backgrounds, and they looked for playful people rather than just pat, brilliant people.
What a fantastic final words. Henry, thank you so much. This was so inspiring, spending an hour with you, sharing your thoughts on healthcare. We touched so many different areas. We could continue certainly for hours and getting more from your tremendous experience. I like very much your thoughts in the sense of man of a problem in managing and collaboration, certainly something which is pretty true, and we have to think about that. But there are many other aspects you shared with us. We will certainly think about, discuss about them. So thank you very much for spending your time with us. Thank you very much, Peter and Christof, for being with us. And again, Henry, thank you so much.
Thank you all, and keep in good health. Bye.
Thank you. Same to you.